The next speaker is Dr. Sumitha Agarkar. She will be speaking on update on management of congenital cataract. Dr. Sumitha is the head of the Department of Pediatric Ophthalmology, Shankara Nethralaya, Chennai. She has numerous publications to her credit, and she is the Joint Secretary of SPOSI currently. Welcome, Madam.
Thank you for the organizing committee for inviting me. And just a small correction there, I'm not the head of the department. Head of the department is still Dr. Surendran. So when we talk about the update, this is 1998 when IMAC was released, Viagra came, France won the World Cup, there was a sandstorm, and in between all these mega changing events, I also completed my fellowship. So, but from then to now, the types of cataract which we have been seeing then and now are more or less similar. We see a whole plethora of children with cataracts which are developmental, traumatic, uveitic, blue dot, steroid-induced nowadays. Thanks to one of the outfalls of COVID has also been because of the digital devices. There has been a little bit of a change in allergic disease also, and steroid-induced cataracts also. I have seen there is a little bit of uptick in past 3-4 years. So what has changed from then to now? Our anesthesia has changed, machines, all these things have modified to a great extent or to a smaller extent. Anesthesia is beyond my scope of talk here. But yes, we have moved from halothane and nitrous-based induction to now very quick induction and quickly deepening the plane, and which is really helpful in pediatric cataract surgery, which was compared because there is a little bit of positive thirst. So I'm very thankful for the anesthetist to adapting to the newer things in anesthesia also. So how the machines have gone from this humble universal 2 to console-based, more and more sleeker designs and voiceovers, to almost like where there is even microscope is not required, you can operate on the screen. So better machines have made a difference, yes, because automated aspiration and a good chamber fluidics keeps the chamber form, prevents meiosis during surgery, preventing unnecessary manipulations. So advanced vitrectomy settings which are available on the newer machines definitely allow us to have a higher cut rate, and finer caliber of like 23 gauge has allowed us less traction on the vitreous. And as a side corollary, it has allowed some of the younger colleagues to implant IOL first and then do a fairly safe PPC and anterior vitrectomy with the newer machines, which was not possible with the older vitrectomy machines which I learned. Surgical techniques, wound construction, these are the basically mean steps of surgical techniques which have not gone major changes in last 20 years, but some of it we will cover it in this. So I think we have moved from scleral tunnels which we did to a clear corneal tunnel, which is again allows us not to open the conjunctiva, and a lot of these children are prone for glaucomas, and you can see if leaving a conjunctiva intact allows glaucoma surgeon to relatively unopened conjunctiva and gives it relief beneath. Clear corneal incisions are also a little less disfiguring and less bleeding, so definitely. But if you look at the wound safety, probably corneoscleral tunnels are still much safer than clear corneal tunnel as far as the integrity of the wound is concerned, especially even when you are putting a suture. Rexis, again, from touch and go of 1990s to now, the holy trinity of good OVD instrumentation which allows you to move through a small side entry, and dyes like Trypan Blue has made job really easy for even people who don't do that many numbers of pediatric cataracts. It has really definitely improved our life here. So as you can see, this patient, it would have been impossible to do a Rexis, but thanks to the dye, at least there is some amount of view in this patient, which was probably I would have lost the Rexis without this dye. The newer technology is a precision pulse capsulotomy or femtolaser capsulotomy. Zeptolaser has been tried in children and has been published. Some data has been published in Indian Journal of Ophthalmology. It is safe, small console relatively, but probably cannot be used in a very, very young child with a very small anterior chamber depth. And femtolaser, of course, you cannot use in combination with general anesthesia, but older children who may allow you to make the flap capsulotomy under local or topical anesthesia, you probably can try it, and it definitely gives you really nice round controlled rexes. Posterior capsular management, because VAO rates are almost 100%, primary posterior capsulotomy is still gold standard, but as I mentioned earlier, with newer machines, probably you can do it even after putting the intraocular lens. Younger children definitely need anterior vitrectomy, but older children you can get away without doing anterior vitrectomy by either using a posterior optic capture method or using a special lens like a bag in the lens. Both these techniques compare well with primary posterior capsulotomy in preventing VAO. So if you are confident about primary posterior capsulotomy and anterior vitrectomy, it is definitely absolutely foolproof. So let me not go through. So this is the bag in the lens. As I said, both the haptics, one flange of the lens is behind the iris and one in the bag, so that there is no migration of the cells happen. So you can do only thing it needs a precisely sized equal anterior and posterior capsulotomy, and we have to capture both the flaps of anterior as well as posterior capsulotomy in the groove which is provided in the lens, and one of the flange goes. So there is absolutely no chance that lens cells will will migrate in the visual axis and cause VAO. But it is still non-foldable lens, requires a bigger incision and not available in India as far as I know. Posterior capsulotomy capture, optic capture, again here you put an intraocular lens in the bag, and without doing a vitrectomy, gently you can push the optic of the bag, optic of the IOL through the capsulotomy into the in front of the anterior haloid face. Again, this will not need any kind of. IOLs have gone a major change. So these are all the IOLs which are available to us now. All of them are still available. Foldable lenses were really the game changers in the real sense of the word. They provided a paradigm shift in the pediatric cataract surgery. Because they allowed the lenses to be implanted through a really small incision, allowed a closed chamber through the surgery. You needed to open the chamber only to actually implant the IOL. And they are biocompatible and have definitely drastically reduced the incidence of postoperative inflammation. So these are the various design of foldable lenses which are available, and now we have a plethora of designs and companies which are coming up with IOLs which are fairly easy to use and insert. But IOLs have also led to more questions. What is the age of implantation, target refraction, IOL power calculation? So can I have 2 minutes more? So age 1 year or older, probably IOL implantation is the standard of care. However, in 2023, it is more of an anatomical decision and not so much as the age of the child. So please consider IOL implantation in any eye if the corneal diameter is at least 10.5 millimeter and axial length is 18 millimeter and child has absolutely no other ocular comorbidities like microcornea, microphthalmos, abnormal angles and everything. But if you are and also I will add another corollary to it, that parents should be willing to come for follow-up, especially if the children are younger. So if you think the follow-up is not going to be there, it's probably safer to leave the children aphakic. Ever in doubt, good aphakia is always comparable to pseudophakia, and it doesn't. Some situations like JRA, actually the cycle has gone full from no IOL to back to no IOL as a standard of care over time because of the complications seen with intraocular lenses. So while we have sorted out age, when it comes to power calculation, it is still complicated. There is presently no consensus on best IOL formula. This is IGO2021 as an editorial. This statement was made, and I agree with it because there are really none of the formulas have been designed for children or capture the data which is, or nor do we have the data always which is required for these formulas to work well. They are fraught with errors in younger children, especially if you are doing the measurements in general anesthesia. Small errors are definitely magnified. A 0.1 error of IUL axial length calculation in a child will be much more, lead to a much more error in the DBR than what you would get in an adult. So even a smaller error in a smaller eye is much more magnified. About the different formulas, there are conflicting data. One formula says this is good, another says no, this is the worst. If you look at the literature, there are, but in best case scenarios, the success rate of hitting right is just about 50 to 60%. So what do we do at this point? We combine two formulas and see the average of the two. SRKT can be used reliably compared to newer generation, and we have just published our data last year on Barrett's formula in children, and you can look, I have put a reference there, and we found that prediction error was same compared to, of course, we used SRK2 as our comparison formula, but you can use a combination of two formulas to get to the correct power, or a mean of 2 or average of 2. I have really no recommendation at this point that this is always gets you the hit at the right thing. What else we are doing differently now in 2023? We are documenting baseline parameters much better. Surgery under anesthesia should be taken as an opportunity to record baseline, like gonioscopy and pachymetry, which we don't do normally, but we should. And examinations, this examination certainly points which patient need more close follow-up. So if you see a slightly anteriorly praised iris, you know this child needs far more stringent glaucoma measurement. If you have a borderline cornea, you know this child needs a more closer follow-up. Imaging modalities like ASOCT certainly improve surgical planning, especially in complex cases like PPC, where you know that there is a posterocapsular. ASOCT can give you a you're much better prepared surgically if you see a posterocapsular dehiscence. However, that does not take away the importance of a good clinical exam. What are we not doing enough? We still don't investigate the causes of cataract as much as we should. Bilateral cataracts need a genetic and metabolic workup, which I think all of us, we don't do enough. Sometimes identifying the genetic mutation can be life-saving in some cases, can prevent morbidities, systemic morbidities if you can pull. And a lot of these children you may be the first point of contact with the medical world because they are coming for cataract, and you can actually point towards their genetic mutation. Costs are coming down for genetic testing, and I think in future it should not be a limiting factor for us to do more genetic testing to know what exactly is genetic mutation pattern in our population. And of course, the search for a perfect IOL formula goes on. What lies ahead? Better biometry, better calculations, and you need to be prepared for long-term complications. You need to be prepared for refractive interventions because these children are going to become more myopic. Some of them will require IOL exchanges, some may require refractive surgeries, and we really don't know at this time what is the effect of time on IOL in a child's eye, where you have put the IOL at age of 2 or 3, and how this is going to look 30 years hence. Maybe something like this. This is one of my old 20-year follow-up, and you can see the lens, although visual axis is clear, child is still read 6/9, but this lens, you know how it is going, and he is still in his early 20s. So I definitely see there will be there will be a time when we have to remove this IOL and put another. So with this I'll end my talk. Thank you very much.
Thank you, madam, for that highly informative talk.